Hello, my name is Amy Boettcher, and today I will be discussing our investigation of the reliability of flow-mediated dilation measurements pre- and post-acute exercise. Flow-mediated dilation, or FMD, is an indicator of endothelial function and is a contributor to cardiovascular health. Figure 1 on the right shows that acute exercise bouts have been linked to chronic changes in FMD. Here we can see that negative responders, or those whose FMD decreased post-acute exercise, also decreased their FMD after 2 weeks of training. Conversely, this quadrant shows that those who increased their FMD after one exercise bout also increased after a 2-week training program. It can therefore be inferred that acute FMD responses will predict chronic change. In this figure, we can also see that individuals responded very differently to the given exercise stimulus. And importantly, test-retest reliability of acute FMD responses to exercise have yet to be established. Therefore, the purpose of our study was to assess the test-retest reliability of the FMD responses to a standardized exercise bout. We hypothesized they would demonstrate substantial reliability. We further wanted to observe individual FMD responses to an exercise bout. Here's an outline of how our FMD measurements were obtained. We started with a baseline measurement of the brachial artery diameter with the participant in a supine position. Then the cuff on the forearm was inflated to 30 millimeters of mercury above each individual's resting systolic blood pressure for a 5-minute period of ischemia. After 5 minutes, the cuff is released and a 3-minute period of reactive hyperemia begins. During this phase is when the peak brachial artery diameter is measured. From these values, we calculated the percent FMD using the equation shown below. We had 11 healthy subjects participate in our study. All participants came to the lab on 2 separate occasions and completed the same protocol each time. Each session consisted of a pre-exercise FMD measurement, which was taken after 15 minutes of rest in the supine position. Subjects then completed a 40-minute exercise bout on a cycloergometer, which included a 5-minute warm-up, 30 minutes of cycling at 60 to 65% of age-predicted heart rate max, followed by a 5-minute cooldown. The subjects then rested in the supine position for 30 minutes, after which the post-exercise FMD measurements were taken. Our intraclass correlation coefficient was set to 0.60 to determine substantial reliability, and our p-value was set to 0.05 to determine significance. Moving on to our results, the first 3 rows in Table 1 show the mean, standard deviation, ICC, and p-values for the pre-exercise baseline diameter, peak diameter, and FMD. The next 3 rows depict our post-exercise baseline diameter, peak diameter, and FMD. This final row shows our change in FMD from pre to post-exercise for both visits. And lastly, this column shows our ICC values, all of which are above 0.60 and therefore show substantial test-retest reliability of these FMD measurements. Figure 2 is comparing the mean FMD for all participants from pre to post-exercise on visit 1. The green bar depicts the pre-exercise mean and the gray bar depicts post-exercise. From this figure, we can see that on average, FMD decreased by 0.06 from pre to post-exercise on visit 1. However, figure 3 represents individual FMD measures pre and post-exercise. Here we can notice that individual differences to the exercise bout. The blue lines represent the individuals whose FMD increased following exercise, and the red line represents individuals whose FMD decreased after the same exercise bout. Pre- and post-exercise measures of baseline diameter, peak diameter, FMD, and the change in FMD are all reliable. These findings of substantial test-retest reliability are important when investigating how acute FMD responses can predict chronic adaptations. Further, individual FMD responses varied greatly and included both negative and positive responses to the exercise bout. To accurately determine the benefits of an exercise bout, individual responses should be studied. A limitation of our study was our sample size. A larger sample size could give a better representation of individual responses and may increase reliability. Future research should look closely at individualized FMD responses to an exercise stimulus to determine how to more accurately prescribe exercise to prevent cardiovascular disease. Thank you for your time.